these days, first, we have a lot of injectable therapies. Earlier, we used to deal with injection phobia. I'm sure most of us have dealt with having to tell our patients to take injections, insulin earlier, so that they are able to better control their sugars. And now we have the other end of the spectrum wherein people come to us for injections to lose weight. Right. So the injection phobia seems to have somehow gone away along this way. And let me see what we go through in the journey. So this is, thank you so much to Manoj, Purvi and Bansi for inviting me here. So today we will talk about the types, the classes of injectables in diabetes, the efficacy, safety, outcomes, the initiation and titration, and patient-centric decision making, also patient concerns and myths. So why do injectables matter? Injectables matter because the burden of uncontrolled diabetes, as we all have been discussing for the last 2 days, is that the burden of uncontrolled diabetes is on an increase. The oral medications we see, they can control only to a certain extent. So maybe HbA1c can reduce by about 0.25, 0.51, maybe 1.5. And then there are injectables now which are available which are beyond insulin also. So insulin, we all know, physiological replacement in type 1 is essential. In type 2, if the patients are out of control. Since you were talking about young diabetics, yesterday I had a patient who was 20 years old, first time detected diabetic, came with an HbA1c of 16. Crazy. And of course, now in that situation, though maybe he will be a type 2 because he had a lot of acanthosis and things like that, but at least initially you have to start these patients on insulin to bring the sugar down, and thereafter the OADs. Better sugar controls, of course, because injectables, the time delivery, the titration, it is more flexible to use. GLP-1 agonists which are available also are used for reduction of weight as well as maintain the blood sugar. Then the expected treatment, which is beyond the tablets, insulin is especially we need to use when we are dealing with people with DK or with hyperosmotic coma. Then the GLP-1 agonists, they lower the blood sugars, they promote the weight loss, and of course they reduce the cardiovascular risk. And then we have dual therapy, which could be insulin and GLP, could be different types of GLPs, and that also is for better improvement with the cardiovascular risk, the obesity, all that. What we also need to, the insulins or the injectables, is for reduction in the complications. We all know that we all work towards controlling the blood sugars so that there are less complications in people with diabetes. Patient-centric flexibility. Nowadays with injectables, there are better devices available. It's not that syringe which you boiled or the needle which you boiled. Of course, we have evolved from that a long time ago, but now the pens are so nice. They have very fine gauge needles, so it's easier to inject. Then those who don't want to take injections every day, there's insulin pump which is available, that is even easier for them to deal with. So they are less painful, and those adjustments can be done because, I mean, you can increase by 2 units, 4 units, whereas in a tablet you can either make it half or you can make it 1/4. 1/8, I don't think anybody can make a tablet, so the doses is easier. Then beyond glucose, like I said, there are additional factors. There is, we always talk nowadays about beyond, matlab whatever the effect we want, but beyond that, what else? Matlab ye, like is dil mange more, but we want some more also. So weight reduction, there is, besides the blood sugar control, there's weight reduction, there's improved blood pressure, reduction in the cardiovascular risk, and there is renoprotective effects which are there. Um, Now the insulin overview. Insulin, we all know, we have different types of insulin. I will not go into this, the types, the duration of action of insulin. Then we also have GLP-1 agonist, again different types. We have short acting, which require to be given daily. We have weekly, and like semaglutide, dulaglutide. And in these, the benefits of course is the blood sugar, the weight, as well as the cardiovascular benefits. These are the list of medications which are available. What is very important is that the mechanism of action, they target multiple pathways. The insulin secretion is increased, glucagon secretion is reduced, appetite is reduced, satiety is increased, and there's a reduction in the gastric emptying. So that's how the GLP-1s work. This is just very brief because I'm sure the other speakers will cover it in their sessions. The clinical benefits is the glycemic control. Finally, we are giving the injectables for glycemic control. So the glycemic control is much better than any oral medication. 1 to 1.5 HbA1c reduction. Weight reduction also about 3 to 6 kgs on an average. Some patients even lose a little more. Cardiovascular protection, as we have seen in the various trials, the leader, sustain, all these. The renal benefits also, it shows a reduction in the progression of the kidney effects. Then the dual antagonist, that's the GLP-1 and the GIP. So this tirzepatide is what is currently available. This acts on the HbA1c, reduces the HbA1c. There's a demand because a lot more people want to take the medication more for the weight loss than for the HbA1c reduction, and they target two receptors simultaneously. So therefore they have much better efficacy as compared to the GLP-1s. Mechanism of action, again it is pretty similar. There's an increase in insulin secretion, reduction in the glucagon and the appetite. The gastric emptying is a little slower. Then the GIP, it improves the insulin release and improves the fat metabolism, which and therefore causes a lot of weight reduction. Finally, the end result is that synergistically they both reduce the weight as well as improve the glucose levels. The clinical benefits, HbA1c reduces to about 2.5 to 2.9%, and about 10 to 15 kilos of weight loss is there. Besides this, the lipid levels, the blood pressure, and there's a proportion of people reaching their diabetes remission because of the weight reduction. Cardiovascular benefits also, there are a lot of studies, as we have seen, the SURPASS as well as the other studies which are ongoing, the cardiovascular renal protection. And what is interesting is the obesity treatment without diabetes also. So the efficacy and the outcomes, the insulin we all know is strongest reducer of the HbA1c as compared to all the other oral medication. The GLP-1s, they reduce it by about 1 to 1.5%. Tirzepatide, about 2.5% reduction in the HbA1c. GLP-1 cardiovascular renal benefits are also there. Side effects, because all patients want to know before they take the insulin, what is the side effect. Before they take the medication, what they eat everywhere else is okay, or they take other things is okay. But when they come to a doctor, I'm sure we all face this nowadays, that what is the side effect. So side effect is that there is hypoglycemia with insulin, weight gain does occur, and with the GLP-1 or the dual agonist, there is a GI side effects, which means the nausea, but which most times I tell them is what is the desired effect. That is the desired effect, so that you eat less and then you are able to lose weight. Rare cases of pancreatitis have been known to happening. Then, so the initiation, of course, for insulin, we start 10 units a day or 0.1 to 0.2 units per kg, and then titrate it. GLP-1s also, you can gradually start and titrate. And sometimes there are combinations of basal and GLP also which can be started. The guidelines all say that first line of treatment before insulin should be either GLP-1 or a dual agonist before insulin in most people with type 2 diabetes. Of course, the gold standard still remains that if there's severe hyperglycemia, then insulin is the treatment of choice. Combination therapies are also available. Now what the patients ask, they want to know, will it hurt? So we tell them that the needles are very painless. In fact, they're so nice nowadays that even if a child is sleeping, you can inject them, and so they should not fear the needle prick. Weight change. Now that depends. If it's insulin, definitely there will be some amount of weight gain. If there's GLP-1, a lot of times they expect that they take one shot and the weight suddenly starts coming down. It doesn't happen like that. It takes its time, and also they have to comply with diet. I had one patient who would take the medication GLP-1, and usually about 7 days, once a week we give. But by the end of it, we all know that the effect wears off. He would eat a whole pizza and come the next day. Obviously, his weight is not going to be low. So they have to know that this is a part of the treatment. It's not the only treatment that we are giving them. So if we don't tell them that, they expect that the next time they will come, they'll be 5 kilos lighter. So we need to talk with them regarding what is the expectation, what will the medication provide. And another thing is insulin, they always think is lifelong, because once you hear insulin, once you tell a patient insulin, they always think that this is going to be for the life. So that doesn't necessarily be there. Then cost is always a factor in our patients, because they always want to know what the cost and how they can get something cheaper, how it can be more efficacy. There can be more efficacy of that. Now, what is very important is we must take time to educate them regarding the site rotation. Site rotation is something which is very important, because if you don't tell them, especially patients who are taking insulin 3 to 4 times a day, if they are not rotating the site of the injection, they will come back later with painful injection sites. They will come back saying, that there are swelling below the injection site, bruises, all sorts of things like that. So you must take time to explain to them how to rotate the site. Storage is also very important, how they store the insulin. A lot of them say, I will not take insulin because I don't have a fridge at home. And they have to be told that it's not required to be in a fridge. I know there are some low cost options also which we have, like putting the insulin in a matka and things like that, because all over the country the weathers are different. There are some places where it's 50 degrees also, and at that time we need to kind of otherwise most insulin, when it is in use, can be kept inside a cupboard as long as they're not exposed to sunlight. What's very important is traveling. A lot of times they tend to put it in the check-in bag. That is disastrous, because the insulin freezes and later on is not as effective. So these are things that we need. Another thing is disposal of needles. They just throw them away, and these can be picked up by rag pickers and recycled. So ideally it should be broken before throwing, and it can hurt the person who's clearing the garbage. So lifestyle, of course, still matters. Insulin or any injectable is just as an adjunct with the other treatment that is there. They have to also learn how to check their blood sugars. They have to know what to do in case of hypoglycemia, because with insulin, hypoglycemia is known to happen. They can also know how to log their sugars and chart them. These days, most of them are very computer savvy. Again, the myths. So, like I said, that insulin they think is the last stage of their life, and but it's not that. It's just a hormone replacement, probably for some time. Of course, in a type 1, it's for longer. Then pens are very safe and can be used. And GLP-1s can support weight loss. Again, like I said, we have to have the expectations done properly. So the key takeaway is that insulin, we know, is life-saving. It's can be used to save person's life, especially people with type 1 or in emergencies, and they are very effective when all other medications fail. They do prevent the long-term complication, and there is a benefit of the cardiovascular and kidney benefits. They empower patients with newer insulin delivery devices, the pens, the pumps, all that. And the GLP-1 and the dual agonists are also very transformative. We have seen them in the last few years. There is an promise of better glucose control, weight loss, and metabolic benefits. But remember that this is just a cornerstone of the therapy. There has to be the other therapies also. There has to be diet, exercise, lifestyle changes which happen, and what's very important is adherence to the medication. With this, I thank you all. Thank you.
Thank
and
you for
we
your
have
talk.
to educate. So just one sec, the last slide. So we, like Pranjali said, that we go to schools and educate the students about lifestyle diseases, obesity, and other lifestyle diseases. So this is something that we all must consider doing to schools which are nearby, to educate them about what are healthy eating habits, just to ensure that our future generations have reduced obesity and diabetes and other lifestyle diseases. Thank you.
Thank you.